Hello and welcome to Askimo TV. I'm talking today to Dr. Petros Vlastarakos. Dr. Vlastarakos is a specialist ENT surgeon. Hi, Dr. Vlastarakos. How are you?
Hello, Joanne. I'm fine. Thank you. Thank you very much for your invitation, and I hope today's interview will be educating to your viewers.
Dr. Vlastarakos, today we're going to talk about the indications for grommet insertion in children. So I'm going to start off with, tell me briefly about the ear and what problems there may be in the ear that would indicate a child needs a grommet.
Well, I think that the structuring point is the middle ear, really. The middle ear comprises of the tympanic membrane, what we call the eardrum. There are also ossicles in the middle ear, and the eustachian tube, which is a small tube connecting the ear to the nose and ventilating the ear from the nose. What essentially happens in most occasions is that there is an accumulation of fluid in the middle ear. That fluid is sterile, or it's perceived to be sterile anyway, what it causes is hearing loss, reversible but hearing loss in children, and we need to address that issue obviously because of the developing child, because of the academic progress of the child, for a variety of reasons obviously. And another indication, of course, is recurrent ear infections. I would say 6 or more in a year may warrant a grommet insertion.
Talk me briefly through the operation and what actually happens.
Can you repeat the question, please?
Talk me briefly through the operation and what someone can expect to happen.
Okay, so what we do in effect is that we make a small incision at the anterior-inferior quadrant of the ear, of the tympanic membrane. Obviously the child is asleep, and we are using an operating microscope to enlarge the image. So we're doing a very small incision, and then we aspirate the fluid from the middle ear cavity. And we insert a grommet, which is a tympanostomy tube. It's a hollow tube made of biocompatible materials. The tube will self-extrude in about a year's time. We're talking about standard ventilation tubes, what we call grommets in most occasions, because they are longer lasting ventilation tubes as well. So they self-extrude in about a year. They can only go out, they cannot go in. And that's it really. The whole procedure doesn't take more than, I would say, 5-6 minutes per year.
If you find that every time the grommet comes out that the child keeps having ear problems, suffering with the ear, where do you go from there in addressing the problem?
Well, I would say that what we really need to discuss with the parents preoperatively is that this may happen. The vast majority of children require one set of grommets, but about 25% of children require more than one set of grommets. Now, we cannot say two, we can only say more than one. What we do if there is a reaccumulation of grommets is that certainly we need to have a look at the nasopharynx at the back of the nose and see if the adenoids are enlarged. If they are enlarged and they are obstructive to the area of the eustachian tube, which, as I said before, is a small tube connecting the ear to the nose and ventilating the air through the nose. So if they are obstructive, and they are mechanically obstructing the eustachian tube, then they need to be removed, and that increases our chances of a successful outcome. Now, I would say that even if there is a strong clinical suspicion or evidence from the clinical examination that there are enlarged adenoids at the back of the nose, at the nasopharynx, then they have to be taken out the first time. But certainly, if the child warrants a second insertion, the adenoids need to be checked. Now, if that persists, I would give it a third try as well, and then there are some alternatives. If even after we have removed the adenoids, even after the third insertion, when there are indications, obviously, but even after the third insertion, the fluid reaccumulates. One option is to put a longer-term grommet. I would say most widely used are the so-called T-tubes. They resemble the Greek or Latin letter T in shape. So these stay in for longer, I would say 5 years, around this, 3 to 5 years, but they can even stay for longer, and they can make certain that the ear is properly ventilated for a longer period of time. Another alternative, obviously, if the child has hearing loss, is to provide hearing aids for the child. That is easier, obviously, in systems like in the UK, where the NHS can provide hearing aids for children cost-free. But certainly, when the parents have to buy the hearing aids, that may be costly, and we don't really address the source of the problem, but we can certainly help the child hear better. Certainly, there can be issues like social stigma because the child is wearing something in the ear. But I would say that modernized Western society, where everybody is walking in the street having a Bluetooth stuck in the ear, have, I would say, contributed to a more acceptable appearance of the children. And of course, there are alternatives, like for instance, the autovent system, which in effect is like a balloon with a tube inserted in the nostril. The child blocks the other nostril and blows with the mouth shut and blows a balloon. And that can be helpful in certain occasions. It can even be tried before giving a shot at grommets. That's a reasonable alternative as well. And obviously, as far as grommets are concerned, we give a reasonable time period for observation of the child. Now, if the fluid is in both sides, that time period is 4 months. If it's one side, it's 6 months. So during this time period, we advise the parents to start the child on Eustachian tube Eustachian tube exercises, like blowing balloons, like chewing gum, if the child is old enough, obviously, and also like blowing bubbles with a straw in water. All these exercises, like the autovent machine as well, have one basic principle. The muscle that moves the soft palate, I would say it passes very nearly the opening of the Eustachian tube. So when it contracts, when, for instance, someone is chewing, swallowing, even yawning, so this is why chewing gum is a very good exercise, it opens the Eustachian tube, so it massages the tube, and it can improve the ventilation of the ear. So all these are alternatives to repeated grommet insertions.
Thank you, Dr. Vlastarakos. Thank you so much for talking to me today.